Raza is a board-certified internist and hematologist and a transfusion fellow at the University of Toronto and Canadian Blood Services. He has an interest in applying big data methods to improve transfusion practice, and is currently involved in a CBS-funded project examining red cell transfusion in the GEMINI network of hospitals. Very happy to have him on board and to have him collaborate with us, along with many of the transfusion fellows in the TTISS Ontario program. Raza, I'll pass it to you.
Thanks so much, Andrew. Can you hear me okay? Just before I begin, I want to double check. All right, thanks so much for having me virtually. I would have loved to be there in person. There's not a transfusion meeting I ever want to miss, but unfortunately had some conflicts related to my MSc. But thanks again for being here. This is an audience that I think really cares about the project that I'm going to be presenting to you folks, and hopefully it's interesting. But before I begin, I want to say that although I'm presenting a new project, this is in very early stages. And as you're going through this talk, please think about things you would improve, because we're at a stage where we're really looking for feedback and soliciting as much as we can. So the project that I'm going to be chatting about is called TTISS-GEMINI. It's surveillance for transfusion reactions in the GEMINI dataset, and I'll be explaining all parts of that title. As Dr. Shi mentioned, I'm a transfusion medicine fellow. I work at Canadian Blood Services and U of T, and I have no relevant conflicts of interest for this talk. I will say I think I've done some AI consulting work, but it's not going to be relevant, even though we will be chatting about that. So in terms of the primary objectives for this talk, the first one is to describe what the project is about, and the second one is to solicit your feedback. And I'm hoping at least 50% of this time, if not more, is dedicated to that. So the problem that we're trying to solve in general that we're interested in is the lack of hemovigilance resources and expertise. The people in this room are really a select bunch, because there's a shortage of knowledge out there. And even in a lot of smaller community hospitals, we know hemovigilance is very low, or in some cases non-existent. And so the goal is really that when we see graphs like this, we know that even the best studies we have of transfusion reaction prevalence and incidence are underreported. And are underestimating the problem. So what are some ways that big data potentially could solve this? And that's what this project is backgrounded in. In terms of, if you look at past literature on studies using large predictive machine learning models or that type of technology on studying transfusion reactions, you'll notice a couple of things. Firstly, that most of these studies are over 5 to 10 years old at this point. I think there will be a slew of them being published again now that this has come in vogue a little bit more. But back then, the technology was a little bit different in terms of what was available in informatics, but they were asking the right types of questions. They were asking about detecting trolley, identifying TACO in a kind of EHR, like electronic health record data set. People were investigating and the value of different types of blood tests, like the proBNP, for classifying pulmonary reactions. And they were using essentially retrospective type analyses to look at these questions and see what can be learned. And if you know a little bit about this field, like some of the machine learning models they were using were actually pretty old and basic, whereas in the last 5 to 10 years, the technology has really accelerated. So we now know a lot more. A more recent report that might have caught your eye in Transfusion Journal was this one, looking at classifying post-transfusion adverse reactions using an artificial intelligence system. So essentially what they had done was that they took about 36 vignettes. They presented these to ChatGPT 3.5, which is now like an older version. And they wanted to see how it performed against physicians who were trying to classify reactions based on the same information. And I'm happy to report, I guess, that AI did not actually do a very good job in identifying most reactions. And overall, compared to TM specialists, it identified 48% correctly compared to 72%. Now, I think 48% is already pretty impressive for a model that has to pick between a slew of different reactions. And I will also say 72% is not so impressive for people like me who consider themselves experts. But nonetheless, this shows that there's still a big gap. And I would say that even the methods the study used are relatively rudimentary. They didn't pre-train a model. ChatGPT doesn't actually know very much about transfusion in general, if you've noticed that it hasn't been kind of pre-trained on a lot of transfusion data. So there are limitations, and even this 48% probably could have been improved a lot more. But now coming to how that relates to our current project. So in this project, we're hoping to use and leverage existing EHR data, so we're not trying to collect new data, to improve the surveillance, knowledge, and care related to transfusion reaction events. And although the project won't directly address all of these upfront, we hope that these will be some of the future offshoots. Our main goals are firstly to perform a linkage between GEMINI, which I'll describe in a second, and TTISS-Ontario, which you of course know a lot about. We're going to hope to train a machine learning model on features of what does a transfusion reaction look like when you look at electronic health record data. Like how can you characterize a reaction or a patient who had a reaction in that data set? Then validate those, the model that we create to capture non-reported reactions, because we know a large number of reactions aren't being reported, but might share a similar profile to the patients who are being reported. And then finally, use that second model to estimate the prevalence of non-reported reactions. I will go into quite a bit more detail in a second. The data sets we'll use are TTISS-Ontario and GEMINI. And with GEMINI, just for people out of province who are not so aware, or even people in province, it's essentially a conglomerate of data that holds electronic health record data for non-surgical patients from 30 hospitals in Ontario. And they do cover all of the TTISS-Ontario Sentinel sites, are all covered within GEMINI. And also soon they're going to have pediatric data and hopefully surgical data in the future. So it's an enterprise that is growing and worth investing in for hemovigilance. And you can technically even get long-term patient outcomes through linkages with organizations that have physician billing codes like ICES in Ontario. So here's the core idea of the project. If you think about all of the transfusion reactions that are happening right now at these GEMINI hospitals, there's some subset of them are reported in TTISS, and then there's subset that are not reported in TTISS. And we know that at different sites, based on the reporting framework and resources, this varies. Then you've got the patients on the other side who are experiencing these reactions. And let's say in this case, we have the example of GEMINI patients. Well, the first step that we're going to perform is to do a linkage, which is going to be both a probabilistic and deterministic linkage, depending on the data that we find, to link the reactions in TTISS to patients who experience those reactions in GEMINI. So that's step one. And then we also have to be conscious of the fact that there are a lot of reactions not reported that these GEMINI patients are also experiencing, which I'll come back to in a second. So in this first step, we'll perform the linkage and we will validate it with a manual chart review, just to make sure that we're really capturing true cases that we expect to capture. And the goal would be to perform a descriptive study, just describing what these reactions look like, what the profile of these patients are, the type of work that we have already seen lots in literature. The second step would be to train a machine learning model. So now we know who the patients are who are getting these reactions, what are the features of those patients, the blood products they're receiving, and so on, and to train a model on those features. The next step would be to now apply that model back to the GEMINI dataset to identify patients who are at high risk of having actually experienced a reaction. So this is a bit quite key. We're not in this step looking for patients who are at high risk for reaction, but patients who got a transfusion and who look like they might have had a reaction. For example, you can imagine somebody got a red cell unit, suddenly their blood pressure spikes, they get a high dose of Lasix, they end up in the ICU, they have infiltrates on the X-ray. Those are features that make you think of a respiratory reaction, and that kind of patient is what we would flag. So in the next step, we will use the model to then find candidates for people who have non-reported reactions, that subset that we really were interested in in the beginning. And once we identify that set of reactions, the goal would be then to validate those reactions again with a chart review to see how many true reactions did we catch, refine a new model that's trained on catching non-reported reactions, because they might be in some systematic way different from the ones that were reported. Maybe they're in certain settings or they have certain other characteristics. And then do a descriptive study of those patients. So that is essentially the overall kind of framework of the study. So far, our progress has been that we've assembled a large team, including both stakeholders from GEMINI and non-GEMINI. We've had initial meetings to discuss linkage feasibility, data availability, and logistics. We have thought about these data sets already, and we have a draft proposal that's at this point, like I would say, medium to advanced in terms of where it's ready for a kind of a grant type submission. And our next steps is to continue to liaise with the teams, work on REB requirements, logistics for project initiation, data sharing agreements, securing funding, as well as continuing to refine the core study plan. And this is where this wonderful audience comes in, because You have great minds for transfusion reactions, what's important in the field, what's feasible, as you are the producers of the data that we would be using. And so we would greatly appreciate your feedback. And Andrew has thankfully offered to help mediate the next part of this session. Will just be to ponder some of these questions as well as any other feedback you may have, and we'll be taking notes as you mentioned that. So that's it for me for now, and thanks for TISS Ontario for having me here at this, as well as Andrew for the opportunity to represent this project.
And thank you for Raza for taking the time, out of your busy schedule and your masters to help us out with this. So maybe before I start, happy to take some discussion on this, and just want to encourage everybody here to be as candid as possible, because I think what we need to hear is essentially not only some of the promise that this approach might have, but also some of the pitfalls we might run into, and these are things that we need to know upfront. And I'll just start even by saying, determining a transfusion reaction from electronic health record data probably is going to have some limitations in terms of whether or not it can pick up everything. Because I will say, even for me as a transfusion specialist, and Raz has kind of pointed out in the literature, even sometimes when I review a chart, if someone hasn't identified something as a transfusion reaction, sometimes it's even hard for me to figure out depending on the documentation, right? So this is something we'd like to explore to be complementary to what we are doing here in the community. But just wanted to level set that to start off with. I see, Philippe, you have your hand up. Maybe we can start with your comment.
Yeah, thank you. And I just want to say hi from Saskatoon, everyone. Raz, it's a really cool looking project. It sounds very exciting. If you can develop tools afterwards, like as an outcome of this, that can help community doctors better report and get better accuracy and harmonization of the reports, I think that would be a really useful outcome. The potential difficulty that I can see is having a good gold standard to compare to. So it looks like from previous studies, you're going to use an expert to make a diagnosis and then compare against them. Is there a way to try and make that more robust, like using multiple experts to come to a consensus on a particular reaction, or any other tools that you think?
Thanks, Philippe. I have a quick answer, but I would also love to hear from the audience online as well as in person. And sort of the quick answer is that we're using the TISS judgment itself as the current gold standard of which reactions truly occurred. And that is what we will train the model on, because we believe that because of the adjudication process and the layers of review at the TISS end as well, we think that's the best available data we have. It's not perfect, but as a gold standard, we'll be using that.
Maybe I'll just open it up to the audience. Like in terms of, I'll just say one of the debates that we had was that, do we start with the TISS data and potentially, there might be like a high degree of bias by just using TISS as like the gold standard of data. But we also kind of struggle with the idea, well, if we just started with chart reviews, sometimes, as we said, it's hard to pick things up. So I guess maybe to this audience, since you know the transfusion reaction so well, like what are the most reliable ways we can identify true transfusion reaction cases?
I have a thought. I don't know if it would be possible to put together like a list of standard cases, like textbook type cases, that you could train the model on as a separate data set. So at least it has a few examples of really robust, like unambiguous cases. I don't know if that helps or not.
So I think what I just heard was, maybe kind of almost setting up, we'll call it like a simulated case of some sort to kind of say what the textbook version is.
Yeah, and if it was a separate data set that could also be used for training.
Okay, that's actually a really interesting idea, Philippe.
Yeah, so what I'm hearing is maybe you can see cases in TTISS that are definite to probable that looking at what they've reported and everything, it's exactly that case, there's no doubt. And maybe take those cases and make a subset of data as a gold standard to start off with.
Can I follow up on that, Joanne? So actually, and not to you, but actually for the crowd, for the audience here, and again, people on who are listening online, feel free to chime in the chat as well. So one of the debates that we had was, okay, if we're going to have a gold standard, are we going to just choose cases that are definite versus definite and probable versus definite, probable, and possible? So we so far are thinking we need a balance of stuff that is accurate versus having enough data to train the model. So we're landing right now probably on definite and probable, but maybe I'd like to hear from this crowd, like, do you see probable as maybe adding noise to the data that might be training such a model based off of your experiences?
I would say at London, we don't use definite very often.
Yeah.
There's always a lot of information that could possibly be that, or but we're pretty sure it's this reaction. So we usually use probable. The only time I usually use definite is with a serological.
Fine. And I see a lot of hands. Sorry, just to recap for our online audience, the comment that was made by Glennis was a lot of times when people enter transfusion reactions, definite oftentimes isn't used very often, but even people who put in probable are fairly certain that this is likely the transfusion reaction. Great point. Akash?
Is the goal of the model to identify cases where you think there is a reaction and then you want to further investigate to classify, or is the model to classify that based off of the data it gathers? What's the goal? Because then you can, I guess, then that would make it a little bit more, do you want the probables and possibles so that it flags that as a unreported reaction, or do you want it to actually be able to classify it?
Yeah, my gut sense, well, okay, maybe, so Akash asked the question, what would be a potential goal of this model? Would it be to take cases that haven't been classified as transfusion reactions and maybe flag them for classification versus actually finding transfusion reactions to actually classify them? Maybe I'll just ask the group here, any thoughts on that?
I do. So I know this is a feature in AI models when it comes to pathology diagnosis, that in general, they are highly sensitive, but maybe poorly specific. So they're very good at identifying features that we may not see with our human eye and flag that for us to review. So to Akash's point, I feel like that could be a useful model where it's flagging reactions that may not have been reported to be reviewed, and then the actual diagnosis or the actual sign-off comes from an expert or a specialist.
Yeah, I think that's a great point, Philippe. And I would say, I think that's one of the interesting promises that I don't quite know, all speaking for myself, I don't quite know how it's going to pan out, but I think there are a lot of things that we use to classify transfusion reactions that we as physician transfusion safety officers know of, but there's probably also factors that we don't know of that are worth exploring that could be brought out using these models.
Yes, totally. I totally agree with that.
Ali, I see you have your hand up, and I'm also going to try to read some chat. Ali, go ahead.
Hi, thank you for the great talk. So, a couple of things following what Philippe said. Well, I think the sensitivity and specificity depends on how you train the model. If you want to train the model in a way that it doesn't miss any cases, then we have to accept a higher sensitivity at the risk of reducing the specificity. And that's the same in the in AI models that are going to be implemented. But what I think is going to be the difficult aspect, and I think the best version of this is one that looks through all the data, all the patients who have been transfused, and then flags these ones might have had a transfusion reaction. But I think the important thing is to try to understand the logic that the system uses, the old black box that we don't know why this one is being flagged while the other one is not. We should try to understand why that's happening. It's a bit more difficult. Maybe it's something for later on, but just leaving it to a black box system to make that diagnosis, I wouldn't feel comfortable.
So I think that's such a great point, Ali, and to call out the idea that, I think with much, that's discussed around, AI, is that sometimes we don't know exactly what's in the box, and even experts don't necessarily understand what's in the box, but we need to know from a clinical perspective. Akash, I see your hand up.
I want to ask, how real time is the data and will this analysis happen?
Yeah.
Is this uploaded every month and so it's all retrospective, or can it be like updated day?
It's a great question. I don't know, Raza, did you want to comment a little bit on Gemini and where things are at in terms of updating data? That's appropriate.
Sorry, could you repeat Akash's question?
Oh, sorry, my apologies. So Akash asked one element that will feed into the feasibility of this model is how often the data is updated and how real time the analyses could be in terms of updating the model.
This is a great question, and I have two answers. So the first answer is that we're, for now, for this project, going to frame this as a retrospective analysis of what we suspect are characteristics of patients who've already had reactions and patients who would have had reactions that were not reported in the system. So really just to characterize what those patients are like. Once we have that model, then you can start to use it for all kinds of things. And one of those things you could use it for is prediction. So both prospectively identifying and flagging high-risk patients, as well as maybe even determining management in some cases. Currently, Gemini data has a frequency of about 1 to 3 months for some of their hospitals and up to 6 to 12 months for other hospitals. So this type of project that we're doing is more a feasibility test of, can such a model be built and can it be used? Now, once it's built, I think individual hospitals have to take it on to implement it. And one example is that it's St. Michael's, where Gemini data is housed full-time, and I think any hospital could do this with their EHR data. They currently have a system which prospectively and actively flags patients who are likely to be transferred to the ICU in the next 24 hours. It's called ChartWatch, and I think they recently published it in the CMAJ. And what that system does is that when I'm on call at St. Mike's doing internal medicine, I get a page at like 11 p.m. at night saying, you need to go check out Mr. Smith because he has a high risk of going to the ICU. I can imagine individual hospitals implementing something like that with a model like this to be warned at the time or just before a transfusion that this patient is a high risk for a certain reaction, remain hemovigilant. I could see that being used, but that implementation would have to be at a hospital level, and it would have to be kind of optimized for your local EHR or whatever your environment is. But you could consider this a first step to work like that in the future.
Great. Thank you, Raza.
I
With
have
that-
a question, yeah. So is this model supposed to automatically capture or alert the I guess blood bank if there's going to be any transfusion reaction? Is it going to be for something that's not reported from the patient care unit, or I'm trying to understand how the system is going to work. It's going to train it. So once it sends like reactions, like for instance, if a patient spike fever, is that going to be alerted to say, oh, maybe the patient has fever and what is transfusion reaction?
It's a great question. So with that is asking that, okay, in a sense, how do we see this model being like operationalized in day-to-day practice? That is it going to pick up things that might be transfusion reactions to send to the blood bank or the transfusion medicine service for us to act on it? And, are we going to be getting every single fever that happens in the hospital as an example? The short answer is, in my opinion, is we don't know yet. And I'll say from my perspective, I think we would like to see one of the goals of this is to flag things that are potential transfusion reactions but not reported to inform the blood bank. But we'd have to figure out the sensitivity and specificity. So we're not getting every single fever, but that would drive us crazy. Plus, I think one of the interesting pieces that I don't quite know yet, but my sense is for some transfusion reactions, it could highlight who might be at higher risk for a transfusion reaction. So we have like a patient who's at high risk for taco, and they're about to have a transfusion order. Maybe that's a flag for the clinician at sort of point of decision making to actually decide, okay, if I'm about to give red cells, maybe I might want to slow down the rate. maybe I want to give pre-transfusion diuretics. These are some of the things we're thinking about how this could be operationalized. The last part is, I will say, I think, we've discussed within our group, and we recognize for everybody here who enters these transfusion reactions, what if we could automate some of that? So if we could take some of the data that maybe the EMRs pick up and start to auto-populate some of the forms that are filled out, maybe that would be a useful adjunct for this type of system as well. Shui?
Yeah, so just to add to what you're saying, Angela, I think this is sort of a really interesting point of this talk is around what are the potential applications of a model like this? And so in our discussion, as we're talking about this model, I think like Akash's questions are pointing to kind of the live applications of actively detecting reactions as they occur, supplementing what we're already doing with TISS. And then to Andrew's point, it's sort of around, well, what else can we do with this model? We know that there's a massive underreporting everywhere in the system. Like I talk to my ICU staff all the time. They're like, oh, there was just an FNHTR. We didn't bother reporting it. Oh, it's just a minor, so I know that this is happening everywhere. So how can we better supplement our current system to actually detect more and more reactions, but not just manually detect them like you and I going to into the charts and going through, charts, but actually in an automated way. And I think that's a really kind of exciting, maybe long-term application of a model like this or models like this, where maybe concurrent to the manual detection that we're currently all working, which is more passive, to have a concurrent active system on the other side, which is also reporting, relatively live, maybe in the last 6 to 12 months, what's actually happening in the system. So that's kind of, I think maybe kind of a long-term goal as well. And I think what's also really exciting is that a system like this, we're talking about TACO, which I think that's on purpose because it's frequent and it's, there's easy vital sign changes that can occur. But there's so many reactions like TAD that we don't understand and there's probably lots of others that we can't really characterize. And so a model like this in the future has also the potential to detect other reactions that we either aren't aware of or don't think about or aren't routinely reported. So there's so many kind of interesting applications of a model like this. And it's, I think it's really helpful for us to kind of talk through what you guys think would be really important as we move forward in the work, because depending on if we're interested in live detection and physician, practice guidance, or if we're interested in kind of the bigger picture, I think it changes how we develop that model.
That's such many great points, Shui. If I can just recap for our online audience, I think I heard that there's lots of directions this could go. One of them is that just if we can get something that's a little bit more frequent and closer to real time, it helps with, augment our passive surveillance system with an additional sort of active component to it that actively searches out for reactions that could happen. One of the other elements I'm hearing is that while we are starting with TACO, because it's common, one of the interesting pieces is that for active surveillance, or I guess it's active surveillance that goes alongside, it would be particularly helpful for reactions that we don't tend to see very often or that are not very well understood. And what we really need from the TISS community and the transfusion medicine community broadly is what you would find most useful in a model like this will help us guide where it should go. Because what we really want this to be is like as a additional service to help augment, the busy activity to do, and certainly to augment on top of your already great expertise that you bring to the table. I just want to call out a few points I'm seeing in the chat, just so it's not forgotten. First of all, I'll call out Jacob's great comment around AI and ML completely replacing physician assessment, and that being probably definitely not a short-term goal. And I would agree. I feel like I've heard from the discussion here that much of what we would probably use this for is if such a model flagged potential reaction and really people, actually went in and confirmed that. But that would decrease some of the workload in terms of us voluntarily needed to be voluntarily reported, or us actively needing to find these reactions, and then also gathering that information together to help reduce maybe some of the friction a transfusion medicine specialist or a transfusion safety officer picking up all this information. Hopefully I captured that right, Jacob. And then I want to point out two great comments by Pam. One is that this, like a documentation template for physicians, would be great, where I think I see this challenge as well. And I think one of the challenges of even trying to pick up reactions for an electronic health record is a lot of it depends on the amount of documentation we're provided. So if people aren't providing the appropriate documentation, it's very hard for us to figure out. And I think that's in my mind, that's a constraint we will have to consider when developing such a model. I also saw Pam had a great comment on that small community hospitals don't typically have transfusion safety officers. And I know many hospitals are advocating for them as best as possible, or sometimes even access to a transfusion physician at all hours. So oftentimes this would be supported by the frontline staff, and then also an analysis of transfusion data done quarterly. So I'm hearing that if we were to apply this to smaller centers, we have to think about it, that data not being updated as regularly, but really use this to really augment the staff there because of you know, the lack of human resources that occur at these smaller sites. This was a great discussion, and I'll maybe just ask if anybody wants to add a closing comment. Nancy.
Yes, I'll just make a comment. It seems to me that one of the problems that we have with applying AI, that if there was a solution of a gold standard test, then that's going to be a lot easier. And this, anybody who's heard Ted Warkentin talk about HIT, you know, he's always saying it's a clinical diagnosis until you maybe get an SRA or something like that. But I think what all of the ideas I've heard today, what they suggest to me is we can learn more information about these reactions, and maybe a gold standard test can be developed. You know, if you suspect that a patient has non-cardiogenic pulmonary edema, people do a chest x-ray and you've got your answer. If it's a hemolytic reaction, people are going to do urinalysis and a DAT if it's an acute hemolytic reaction. And unfortunately, for so many transfusion reactions, it's more of a clinical diagnosis, and that's what makes it challenging. But I'm thinking, and I'm hoping as you proceed, the whole group proceeds with this, that you think about how you can understand some of these reactions, whether it's through AI and identifying risk factors, but then also think about, is there a gold standard test that would be easy to implement and you would have your answer? And I think we might hear more about that from the Toronto group related to tackle this afternoon, or I'm hoping that we do. But yeah, that's my comment.
Great. Thank you, Nancy. And again, just for people listening, and if you didn't hear it, Nancy made a great comment about probably one of the biggest challenges in transfusion reactions is identifying a gold standard, identifying definite transfusion cases or definite transfusion reactions where, you know, unlike many conditions, which, you know, you can diagnose with a gold standard test, a lot of times transfusion reactions tend to be a clinical diagnosis and a clinical gestalt to go along with laboratory and diagnostic markers. And absolutely, that's a challenge. But also there's an opportunity I'm hearing where maybe by learning more about transfusion reactions through, you know, artificial intelligence, machine learning, we can learn more about these transfusion reactions to actually better understand ourselves what a gold standard might mean.
Right, and you know, with TEDS 4T criteria for identifying HIT, there may never be a lab test for some of these things, but maybe there can be a clinical conglomeration of findings that people recognize as a gold standard.
Yeah,